everyone. I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. So in this session, I will be discussing a very important topic in the neurology, that is the Parkinsonism. So this Parkinsonism, let me tell you, it is an extrapyramidal disorder. An extrapyramidal disorder in the sense, the pathology is within the basal ganglia. Right, the pathology is within the basal ganglia. And there is decrease in the dopamine levels. Right, there is decrease in the dopamine levels within the basal ganglia, and that will result in the development of the extrapyramidal disorder. Now, you need to know the components of the basal ganglia. So, basal ganglia consists of the following structures, and let me exactly tell you where will be the problem in patients with the Parkinsonism. So, basal ganglia, it consists of the structures like caudate nucleus, then next we have the putamen, followed by the putamen we have globus pallidus, and next to the globus pallidus we have substantia nigra, and next we have subthalamic nucleus. Right, so these are the structures which are present within the basal ganglia: caudate nucleus, putamen, globus pallidus, substantia nigra, and as well as subthalamic nucleus. Now, where exactly will be the problem in patients with the Parkinsonism is, that is in the substantia nigra, where there is decrease in the dopamine levels. Now, you should know that we have two forms of Parkinsonism. One is primary Parkinsonism and the other one is the secondary Parkinsonism. So, if you take this primary Parkinsonism, right, what exactly is the etiology is not known. So, this we call it as Idiopathic Parkinsonism. Right, this we call it as Idiopathic Parkinsonism, right? Or the other name of this particular primary Parkinsonism is, it is also called paralysis agitans. Right, it is also called as paralysis agitans. And we don't know what is the cause here. Whereas, you take secondary Parkinsonism, right? We have an underlying etiology causing Parkinsonism here. So, Parkinsonism, it can be secondary to encephalitis, right? That is called post-encephalitic Parkinsonism. And it can be secondary to toxins. Now, what are the toxins which will cause the Parkinsonism? The toxins which will cause Parkinsonism include carbon monoxide, and the second important substance is manganese, and the next important substance is MPTP. And this particular MPTP, right, it stands for methylphenyl tetrahydropyridine. Right, methylphenyl tetrahydropyridine. Okay, so these are the toxins which will cause the Parkinsonism. Then, if you see the drugs which will cause Parkinsonism, that includes metoclopramide, which is a dopamine receptor antagonist, and this particular metoclopramide, it is also an anti-emetic drug. Then followed by that, we have drugs like reserpine. Then next we have phenothiazines. Followed by that we have butyrophenones. Right, so these are the drugs which will cause the Parkinsonism. One is reserpine, phenothiazine, metoclopramide, and then butyrophenones. Then secondary to ischemia, there can be development of Parkinsonism, and that we call it as vascular Parkinsonism. Right, and even tumors in the basal ganglia can cause Parkinsonism, and punch drunk syndrome. Right, so you will commonly come across this particular punch drunk syndrome in boxers, resulting in the development of Parkinsonism, and certain infections can cause Parkinsonism, example HIV and as well as the influenza. Right, HIV and as well as the influenza. So these are the secondary causes for the Parkinsonism. So we have primary Parkinsonism, secondary Parkinsonism, and then we have what is called Parkinsonism plus or Parkinson's plus. So here it is the scenario where you have degenerative disorders with prominent additional neurological features will be there. That is called Parkinson's plus. And what are the disorders which come under your Parkinsonism plus? That includes number 1, progressive supranuclear palsy. Right, and then followed by that, second we have multi-system atrophy or multiple system atrophy. Right, and third important clinical condition is the Scheidegger syndrome. Right, Scheidegger syndrome. Then followed by that, the other important disorder which comes under Parkinsonism plus will be the Huntington's disease. Then the other disorders like Wilson's will have the features of Parkinson's plus, and this particular Parkinson's plus, it is also called atypical Parkinsonism. Right, this is also called this is also called as the atypical Parkinsonism. That is what is called as the Parkinsonism plus. Now you need to know what are the features of the Parkinsonism. Okay, before going ahead with the features of the Parkinsonism, let me tell you that what is the most common cause of the Parkinsonism. Right, we have discussed many etiologies. So among the various etiologies, let me tell you the most common cause of Parkinsonism will be Parkinson's disease. Parkinson's disease, that will be the most common cause of the Parkinsonism, but it is the second most common neurodegenerative disease. Neurodegenerative disease. So please remember this point, that Parkinson's disease, it is the most common cause of Parkinsonism, but among the neurodegenerative diseases, the Parkinson's disease, it is the second most common neurodegenerative disease. Then what will be the first common or most common neurodegenerative disease? The most common neurodegenerative disease will be Alzheimer's disease. Right, that will be Alzheimer's disease. Okay, so what is the hallmark features of the Parkinsonism? The hallmark feature of the Parkinsonism is that there will be degeneration of dopaminergic neurons. Right, there will be degeneration of dopaminergic neurons. And where are these particular dopaminergic neurons present? These dopaminergic neurons are present within the substantia nigra. Right, these dopaminergic neurons are present within the substantia nigra pars compacta, and due to which there will be reduced striatal dopamine. And in these individuals, within the neurons, that is within the cytoplasm, you have the presence of the proteinaceous inclusions. Right, so within the cytoplasm, you have the presence of the proteinaceous inclusions. And these proteinaceous inclusions that you will have in case of the Parkinsonism will be the Lewy bodies. Right, these proteinaceous inclusions within the neurons will be the Lewy bodies. Okay, and the protein that you will have within the Lewy body is alpha-synuclein protein. Right, so alpha-synuclein protein, that will be the protein within the Lewy body. Right, so please remember, Parkinson's disease, it is the second most common neurodegenerative disease. The most common will be Alzheimer's, but Parkinson's disease is the most common cause for Parkinsonism, and the pathological hallmark in Parkinson's disease is the degeneration of dopaminergic neurons in the substantia nigra pars compacta, where there will be reduced striatal dopamine and intracytoplasmic proteinaceous inclusions known as the Lewy body will be present, and the protein within the Lewy body will be alpha-synuclein protein. Now, let me discuss few points about the most common neurodegenerative disease. The most common neurodegenerative disease will be the Alzheimer's. And what will be the inclusion bodies in Alzheimer's? That will be the Hirano bodies, whereas in Parkinson's it is Lewy bodies. Right, so it is here the Hirano body. Right, and what will be the protein that will be present in this particular the Hirano body? See, the protein that you will have in the Hirano body will be the tau protein, right, which gets accumulated. And this Alzheimer's, it is called a tauopathy because tau protein is present within the Hirano body. And the neurotransmitter that will be reduced because of the accumulation of tau protein in Alzheimer's disease will be acetylcholine. So, acetylcholine is reduced. Right, the acetylcholine is reduced. And where exactly will be the pathology in case of the Alzheimer's? The pathology in Alzheimer's will be in the nucleus of Maynard-Basalis. Right, nucleus of Maynard-Basalis. Okay, so that will be the site of pathology in case of the Alzheimer's. And this nucleus of Maynard-Basalis, this will be the seat for short-term memory. Right, this will be the seat for the short-term memory. Right, now we will go back to the Parkinson's. So what did I tell you? Parkinson's disease, that is the most common cause for Parkinsonism, and the earliest manifestation in Parkinsonism, right, the earliest manifestation in Parkinsonism will be the tremors, right, tremors will be the earliest manifestation. So earlier the clinico-pathological correlation was in such a way that if there is presence of resting tremor, right, if there is presence of the resting tremor, and that too asymmetrical, and if there was a good response with levodopa, right? If there was a good response with levodopa, that was used to, then we used to consider that it to be a Parkinsonism, right? We used to consider that it to be a Parkinsonism. But we have the revised criteria now. The revised criteria, previously only just presence of resting tremors, that too asymmetrical, and a good response to levodopa was more likely to predict the pathological diagnosis of Parkinsonism. But we have the revised criteria, and the name of this particular revised criteria is UK Brain Bank criteria. Right, UK Brain Bank criteria. See, according to this UK Brain Bank criteria, right, this is a revised criteria. According to this criteria, you require to have the three important manifestation. And what is the three important manifestation is the RAT. RAT will be the triad of Parkinsonism. And what does this particular RAT includes? R stands for rigidity. And what type of rigidity you will have and all we will discuss. A is akinesia. T will be tremors, that is resting tremors. So if 2 out of 3 features are present, right, if 2 out of 3 features are present, that is suggestive of Parkinsonism. Right, that is suggestive of Parkinsonism. Now, to this, recently a criteria has been added, and that particular criteria which has been added is response to levodopa. Right, recently an added criteria is response to levodopa. Now, for example, if the individual has a good response, then it is called the typical Parkinsonism. And if the individual has the poor response, that we call it as atypical Parkinsonism. Right, that we call it as atypical Parkinsonism. That is what is your RAT. Right, RAT is a triad of Parkinsonism. Right, that means rigidity, akinesia and tremors. Out of this, if 2 are there, it is suggestive of Parkinsonism, and recently added criteria is response to levodopa. If it is a good response, typical Parkinsonism. Poor response, atypical Parkinsonism. Now, what is the most common cause of Parkinsonism? That is Parkinson's disease. And in Parkinson's disease, the gene which is being mutated is the PARK gene. So, where is this particular PARK gene present? Is it present on chromosome 1, 2, 3, 4? Let me tell you, the PARK gene, it is present on the chromosome 1. Now, let me take up the detailed discussion of the etiologies causing the Parkinsonism. So, I said you, the Parkinson's disease, right, Parkinson's disease, right, already I have discussed, right, I have said you primary Parkinsonism, secondary Parkinsonism and Parkinsonism plus. Primary Parkinsonism is idiopathic. Secondary Parkinsonism is you have an underlying cause. Parkinson's plus will be atypical Parkinsonism, right, where you have an additional neurodegenerative features. But here, let me try to explain the mechanisms as well. So, Parkinson's disease, you know, it is a genetic disorder causing Parkinsonism, and that will be the most common cause for Parkinsonism. And the defect in case of the Parkinson's will be in the PARK gene, right? There will be PARK gene mutation. And where is this particular PARK gene present? This is present on the chromosome 1, right? This is present on the chromosome 1. Now, apart from that, there are also certain drugs causing secondary Parkinsonism. What is the most common drug causing secondary Parkinsonism? Antipsychotics, anticholinergics, antiemetics, and then antibiotics. So please remember, it is your antipsychotics that will be the most common drug causing the secondary Parkinsonism, right? And what these particular antipsychotics do, right? Why do they cause the Parkinsonism? These antipsychotics, they reduce the level of dopamine, right? They reduce the level of dopamine and they increase the level of the acetylcholine. And how do you treat this particular drug-induced Parkinsonism? The treatment is you need to give benzexol. Right? Treatment is you need to give benzexol, which is an anticholinergic agent. Right? Which is an anticholinergic agent. And followed by this benzexol, the other drug is trihexyphenidyl. Right? That is trihexyphenidyl. Right? So these are the drugs that are given in the treatment of drug-induced Parkinsonism. Right? Then followed by that we have endocrine disorders causing Parkinsonism. Endocrine disorders causing Parkinsonism, hyperparathyroidism, hypoparathyroidism, both A and B, and then diabetes insipidus. So endocrine disorders causing Parkinsonism include both your hyperparathyroidism and hypoparathyroidism. Both of them will cause the Parkinsonism. Now let me explain you how does this hyper and hypoparathyroidism will cause Parkinsonism. See, in patients with hyperparathyroidism, there will be development of the hypercalcemia. And whenever there is hypercalcemia, that will cause the calcification of the basal ganglia. Right, that will cause the calcification of the basal ganglia. Okay, so whenever there is calcification of the basal ganglia, there will be degeneration of the substantia nigra. Right, there will be degeneration of the substantia nigra. And because of the degeneration of the substantia nigra, there will be decrease in the dopamine levels. Then you take in patients with the hypoparathyroidism. So in patients with hypoparathyroidism, why is that there is development of the Parkinsonism? See, hypoparathyroidism causes increase in the phosphate levels. So in hypoparathyroidism, what happens? There will be decrease in the calcium and increase in the phosphate, because if parathormone is not there, the phosphate excretion does not occur. And this increased phosphate, it will try to form the precipitate with the calcium whatever is available, right? Whatever is the available calcium present, this increased phosphate will form a precipitate with the calcium, and that will result in what is called the formation of the calcium phosphate. And this particular calcium phosphate, this will go and get deposited within the basal ganglia. Right, this will go and get deposited within the basal ganglia, causing Parkinsonism. Right, causing Parkinsonism. So these are the endocrine disorders which will cause the Parkinsonism. Then followed by that, I have discussed about the toxins. All of the following toxins will cause Parkinsonism except carbon monoxide, carbon disulfide, manganese, magnesium. So it is the magnesium which will not cause the Parkinsonism, whereas the carbon monoxide, carbon disulfide and manganese, all these three will cause the Parkinsonism, but not the magnesium. Okay, now you should know what will be the ante-mortem findings of carbon monoxide poisoning. Okay, so carbon monoxide ante-mortem findings is that these individuals, they will have the cherry red lips. Right, they'll have this cherry red lips, and definitely there will be the basal ganglia malfunction, And because of the basal ganglia malfunction, you will have the features of Parkinsonism. And how do you treat this carbon monoxide poisoning? You need to give hyperbaric oxygen. Right, you need to give hyperbaric oxygen, right? So that will be the treatment for the carbon monoxide poisoning. So ultimately, overall, if you see the overall clinical features, so after having discussed about the discussion on etiology causing Parkinsonism, so if you see the detailed discussion of the clinical features in patients with the Parkinsonism, see, one important thing already I have said, that is RAT, that is rigidity, akinesia, and as well as tremors. These three are the very important features. These three are the very important features in patients with the Parkinson's disease. And the next important thing is the gait disturbance. And what will be the form of gait disturbance? Right, what will be the form of gait disturbance in Parkinson's? I will discuss that in detail. So you have what is called the festinate gait in patients with the Parkinson's. I'll discuss that in detail. And in these individuals, they also have postural instability. Right, postural instability. We will discuss that in detail about the postural instability as well. These are the cardinal features: rigidity, akinesia, and as well as the tremors. Now, apart from these cardinal features, you also have the other motor features as well. Now, what are the other motor features? These individuals, the letters whenever they write or the words whenever they write, they have a very small handwriting, or we call it as the spidery writing. So, that we call it as micrographia. Right, micrographia, right? So where you have the words or letters being very small. Then they have what is called masked faces. Right, so where you have the expressionless face. Right, you don't have any expressions within the face, that is called masked faces. And then reduced eye blink. Right, reduced eye blink, that is slowness of the movement of the eyelids, that is called reduced eye blink. Then followed by that, you have the soft voice. And this particular soft voice, it is called as the hypophonia. Right, it is called hypophonia, which is called soft voice. And they also have difficulty in swallowing, that is called dysphagia. Right, and they have the freezing movements, that is slowed movements. Okay, so these are the other motor manifestations apart from rigidity, akinesia, gait disturbance, and postural instability. And these individuals, they also have the non-motor features. And these non-motor features include loss of sensation of smell, and that is called anosmia. Right, so this anosmia is loss of sensation of smell. And these individuals will also have the sensory disturbances, and this particular sensory disturbances will be in the form of disturbance within the pain. And they have mood disorders. Right, this particular mood disorders will be in the form of depression. Right, this will be in the form of depression. And they also have sleep disturbances. Right, and they also have autonomic disturbances. And these autonomic disturbances will be in the form of orthostatic hypotension. Right, will be in the form of orthostatic hypotension. Then gastrointestinal disturbances. Right, and there will be also sexual dysfunction as well. right? So these are the non-motor features that you will come across in patients with the Parkinsonism. And let me tell you about this anosmia. Anosmia, it precedes the development of motor symptoms by almost 4 years. And among all these, the resting tremors, that will be the earliest manifestation that you will come across in patients with the Parkinsonism. Now, you see this question here, non-motor manifestation in Parkinsonism. Non-motor manifestation in Parkinsonism, the options are anosmia, loss of vibration, loss of unconscious proprioception, loss of temperature. Non-motor manifestation in Parkinsonism is anosmia, right? That will be the non-motor manifestation. And you see the next question. Features suggestive of drug-induced Parkinsonism is. The options are motor symptoms are generally rapid in onset and bilateral. Motor symptoms are generally gradual in onset and unilateral. Rigidity common. Resting tremors are common. Let me tell you, in case of drug-induced Parkinsonism, so I have said you antipsychotics. They are the common drugs which will cause Parkinsonism. So, in case of drug-induced Parkinsonism, let me tell you, the motor symptoms, they are generally rapid in onset and as well as bilateral. Right, rapid in onset and as well as bilateral. These are the features of the drug-induced Parkinsonism, right? So, drug-induced Parkinsonism, it is slightly different from the features of the Parkinson's disease. In Parkinson's disease, you have the gradual onset of symptoms. Whereas, in case of drug-induced Parkinsonism, it will be rapid onset of symptoms, okay? And in case of the drug-induced Parkinsonism, rigidity and resting tremors are uncommon. Right, rigidity and as well as the resting tremors are uncommon in case of the drug-induced Parkinsonism, right? Now, let me discuss in detail about the earliest manifestation of Parkinsonism. What is the earliest manifestation of Parkinsonism? That is tremors. And these particular tremors, they are classically the resting tremors, right? Classically, they are resting tremors, right? And this particular tremors, they are absent with action, right? They are absent with action or on attainment of the posture, right? On attainment of the posture or by doing the action, these particular tremors, they are less prominent or absent. And if you take the frequency of this particular tremors, the frequency, it is slow. And what is the frequency at which these tremors will appear? That is 4 to 6 Hz only. And if you take the appearance of these particular tremors, they have typical pill rolling appearance. Right? They have this typical pill rolling appearance. Right? And these particular tremors, they also disappear in sleep. Right? So these are the features of the Parkinson's tremors. Right? So these tremors, they are classically seen at rest. They are absent with action or posture. The frequency of these tremors is slow, that is around 4 to 6 Hz. And in some patients, they have typical pill rolling appearance and they disappear in sleep. Then followed by that, the bradykinesia. So bradykinesia is what? It is the scenario where the movement of the individual, it is slow. Right? The movement of the individual is slow and as well as delayed. Right? And as well as delayed. And this slowness of movement, right? This particular slowness of movement, initially it is in the distal part of the extremities. Right? Initially it is present in the distal part of the extremities. Later, it will progress to the proximal muscles. Okay, later it will progress to the proximal muscles. That is what is your bradykinesia. And there are many manifestations of bradykinesia. And what are these many manifestations of bradykinesia? That includes, right, that includes reduced facial expression, right, drooling of saliva, followed by that reduced blinking, and if you take the arm swing while walking, there will be also reduced arm swing while walking, and there is also difficulty in turning in the bed, right? So there is also difficulty in turning in the bed, right? Or there is also difficulty in rising from a chair, right? There is also difficulty in turning in the bed, or there is also difficulty in rising from a chair, and there is also slowness of gait, and they have small shuffling steps. That is what is your bradykinesia. So bradykinesia is that where the movement of the individual is slow and delayed, and this slowness of the movement is initially distally, later it is proximal. And there are many manifestations of bradykinesia, including reduced facial expressions, drooling of saliva, reduced blinking, reduced arm swing, difficulty in turning the bed, and as well as the slowness of gait, right? And the repetitive movements show slowing and as well as reduced amplitude, right? Repetitive movements, they show slowing and as well as reduced amplitude. Even the finger movements are affected. The finger movements, they become, right, the finger movements, they become clumsy and labored. And I have said you about the handwriting. The handwriting becomes small and spidery at an early stage, right? That is what is called as the micrographia. Now, I was also discussing about the rigidity, right? So, rigidity is like where there is increase in the tone of the muscles, that is within the extremities. So, this rigidity in upper limbs, the type of rigidity that you will have is the cogwheel rigidity, right? Whereas in the lower limbs, the type of rigidity that you will have is the lead pipe rigidity, right? Cogwheel rigidity in the upper limbs and lead pipe rigidity in the lower limbs, okay? And what exactly is the difference between cogwheel and as well as lead pipe rigidity? Lead pipe rigidity is the term used to describe the hypertonicity felt in a Parkinsonism limb throughout the range of movements of the joint, okay? So here there is increase in the tone throughout the movement of the joint, right? Increase in the tone throughout the range of movements of the joint, right? That is what is called the lead pipe rigidity. Whereas you take cogwheel rigidity. So cogwheel rigidity, it elicits ratchet-like start and stop movements, right? Start and stop movements, and this start and stop movements will be there throughout the range of motion of a joint, okay? So it is not a continuous resistance throughout the movement of the joint like in case of lead pipe. So you will have a resistance, that is the start of the resistance and then stop. Start and stop, start and stop. So the resistance will not be continuous in case of the cogwheel rigidity that you will see in the upper limbs. Then followed by that, if you see the gait of these individuals, there is delay in the initiation of the gait. Right, there is delay in the initiation of the gait. Right, these patients, they become intermittently stuck and they are unable to move. Right, they become intermittently stuck and they are unable to move. Eventually, it is impossible to walk unaided. Right, eventually they have to use, right, eventually it is impossible to walk impossible to walk unaided. And the characteristic gait what you will have in patients with the Parkinsonism is festinate gait. Right, the characteristic gait is the festinate gait, where the individual will have a short shuffling steps. Right, short shuffling gait with stooped posture. Right, with stooped posture and reduced arm swing. Right, reduced arm swing. That is what is your festinate gait. Right, festinate gait is that where you have a short shuffling gait, stooped posture and reduced arm swing. Right, and in these individuals there is increased falls. Right, falls increase and the gait develops into a typical slow shuffling walk with small steps on a narrow base. What exactly you mean by this word, the festinate? Like the narrow base. Okay, so let me just revise. There is delay in the initiation of the gait of the individual and the patient become intermittently stuck and unable to move, and eventually it is impossible to walk unaided. And in this festinate gait, they have a short shuffling steps, stooped posture and reduced arm swing. That is what is the characteristic gait in these patients with the Parkinsonism. And they also have the postural instability. Postural instability, it is not often an early symptom. These postural reflexes, they are not preserved. Right, postural reflexes, they are not preserved. These patients, they have the tendency to topple forward or backward. Right, tendency to topple forward or backward if pushed or pulled. That will be the postural instability. So because of loss of these postural reflexes, they have increased tendency to fall. They'll have the frequent falls. Next, coming on to the blink rate. So even the blink rate is reduced in these patients. And why is that? That is due to stiffness within the eye muscle. Because the blink rate is reduced, these individuals, they will have the development of exposure keratitis, right, where there is the inflammation of the cornea, and they have this characteristic sign called Meyerson sign, right. So with glabellar tap, there is reduced eye blink, that is called the Meyerson sign. Okay, so there is right? There is reduced eye blink upon the glabellar tap. Normally when you tap over the glabella, the eye blinks, but here there will be a reduced eye blink, and upon glabellar tap, that is called the Meyerson sign. And if you take the face of these individuals, they have like expressionless face, and that we call it as mask-like faces, right? That we call it as mask-like faces. And the other important feature will be depression, right? So depression and as well as mask-like faces, they are the other features, right? Next, followed by that, you see this question: in Parkinsonism, which of the following feature is not present? Tremors at rest, past pointing, akinesia, rigidity. Let me tell you, the one which is not seen in patients with Parkinsonism will be the past pointing. So where do you have this past pointing? It is a feature of the cerebellar disease, right? It is a feature of cerebellar disease. Now you see a question here: wheelchair sign of Quinn is used as a typical red flag sign in Idiopathic Parkinsonism, Atypical Parkinsonism, drug-induced Parkinsonism, Thomson disease. So wheelchair sign of Quinn, it is seen in patients with the Idiopathic Parkinsonism. See, what is this particular wheelchair sign of Quinn? It is the diagnosis of Idiopathic Parkinsonism. Some patients with Parkinson's disease, they may eventually become totally dependent and wheelchair bound. They are unable to stand unaided, right? And they are unable to stand without any particular support. Okay, that is what is called as the wheelchair sign of Quinn. So it is the permanent dependency that you will have in these patients with the Parkinsonism. They are completely wheelchair bound. Okay, so which is seen in patients with the Idiopathic Parkinsonism. Now let me just show you some of the most frequently asked questions on Parkinsonism. Number one, the tremors, that is resting tremors, and the frequency is around 4 to 7 Hz. Type of rigidity, cogwheel rigidity in the upper limbs, lead pipe rigidity in the lower limbs. And what about the postural reflexes? They are not preserved. That is the reason why these individuals, they have the tendency to fall. Characteristic gait will be the festinate gait, where the individual will have a slow shuffling steps with a narrow base. And what will happen to the movement? The movement is slow and delayed. That is called bradykinesia. And what will happen to the handwriting? The handwriting becomes small and spidery. That is called micrographia. They will have like mask-like faces. That is called expressionless faces. And tendon reflexes, they are unaltered. Why? Because Parkinsonism, it is an extrapyramidal disorder. Whereas the deep tendon reflexes, they are dependent on the pyramidal tract, that is corticospinal tract. That is not affected in case of Parkinsonism. So that is the reason why the tendon reflexes, they are unaltered. And what will happen to the plantar reflex? The plantar reflexes flexor in response. That will be, these are some of the most frequently asked questions in the Parkinsonism. Now you take the investigations in patients with the Parkinsonism. One of the very important investigation is the PET scan. Right? And what this particular PET or SPECT will show, right? PET or the single photon emission computed tomography, what it will show? It shows reduced uptake of striatal dopaminergic markers, right? Reduced uptake of striatal dopaminergic markers. Right, that is what you will come across in the PET scan, right, where particularly that is within the basal ganglia, right. And coming on to the treatment of Parkinsonism.